opportunity here. And the same applies for working together with the neurosurgeons. This is not anything you can do just on a call, like, oops, there's pituitary, do you have time tomorrow? Let's do one, the first. Which is, by the way, how we started, but you shouldn't do it this way. This requires a lot of very, very painful training of getting used to each other and a very long learning curve. So, having said all this, let me try to water the other appetite first. Why not start with something cold? 10 days ago, if you looked out of my window at home, it still looked like this. It has all thawed away, but only in the last 5 days or so. So we had a very, very beautiful winter. Looking out of my window, this is how we feed the birds, because in winter they can't find anything up there. This is morning sports. Cleaning the entrance to your house, just in case you quarrel about, again, it's raining here in Jakarta or elsewhere. This is not so funny either. And but walking around can be a miracle situation over there. If you take a stroll through the snow everywhere, is quiet, is silent, unless you have to clean and to drive your car. But again, that is a different story. Okay. Having said this, let's go to the real thing. We will transgress what has come up in FES. Before we talk about surgery, and most of you have come here to listen to surgery, well-proven, new advances, etc., please, and this is for the ENT doctors, understand one thing, which was always there, but never really listened to when people talked about FES. FES is a concept. It has some surgery in it, but it was created and still has the main function to avoid surgery. There is way too much of surgery on that globe in the nose and in the sinuses. So using an endoscope, using a FES approach should save our patients from surgery. And if we cannot do that, it should save the patients from over-radical surgery, which is still performed worldwide. Think of all the tens of thousands of inferior turbinates every year which are sacrificed in a senseless, routine fashion all over the globe. There's hardly any indication for that. Taking an endoscope, being able to look into the nose to understand anatomy, physiology, we should be able to learn and do better service to our patients. This is the idea behind FES. Yes, we still have to operate on many cases, but some of those that you have seen here just previously, polyps, which we still do not know what brings them about. After 30 years of research, isn't that interesting? Are an inflammatory condition for which there will be medical solution and not surgical in the long run. I'm saying this especially for the young people amongst you. Think of it. So FES may have very limited approaches, usually advanced in the future. Now we have it, but keep in mind avoiding surgery. Having said this, of course, there is a beauty of where we can go to. We can take the nostrils as an approach to the sinuses, yes, of course, but we can go well beyond that. We can now reach, in four-handed techniques, the pituitary. You can go beyond the pituitary. You can go to reach the clivus. You can go down to a craniocervical junction. Resecting the odontoid, the dens, is not a problem. It's difficult, but it can be done, and you will see it over those couple of days. We can go to the lateral recess of the sphenoid. We can go to the temporal lobe, infratemporal fossa, behind the maxillary sinus, angiofibromas. And we can go intracranially on purpose, not by accident, like it used to be in the past. All this will be shown, but don't forget this is the extended approach that we love to do together with neurosurgeons, and I hope at some stage the neurosurgeons will love to do it together with us. But basically, when we talk about FES, we talk about avoidance of surgery, at least of unnecessary radical surgery. Don't get the wrong impression on instruments. There is no one instrument that can replace your knowledge of anatomy, your dexterity, your talent, and your diagnostic skill. It is all there. And as you have heard, your eye and brain-hand coordination is crucial, regardless of what instrument you use. Shavers are very nice. They help you in doing things, but you must understand the system. A shaver will absolutely not improve the outcome of your surgery. You may be a bit faster. It may help you to avoid a more bloody field, but there is no change in outcome. You can achieve the very same with traditional instruments, with not powered instruments. The potential for doing an office-based improvement, which, by the way, if you permit me, I would not call FES an office-based polypectomy. You look with an endoscope and you resect the polyp, which may be good for the patient, but it's neither a solution of the problem, nor is that FES. But it is a help, doubtless. So, yes, you're all familiar with that. I'm showing this, that things should be combined. Using FES with standard instrumentation, with a shaver. Shavers don't give you the good tactile feedback, but you will see in this very pronounced disease that at the end of the procedure, you still have all the basic anatomy there. The turbinates are there, and much more than that. What is there is all of the mucosa in the cavity that you have created. If, like here, you have to go for a more or less total sphenoethmoidectomies, there is hardly ever any indication to resect the turbinate. It may be more difficult for you, but it should be difficult for you, for us, but good for the patient. Having difficulties in manipulation never should be taken as an excuse to resect turbinates. Turbinates they carry the nasal mucosa, and the nasal mucosa is the functioning organ of the nose. So if at the end of the procedure you look in here, you see a couple of things. You've seen that maxillary sinus. On a CT scan, it was totally opacified. Our fathers in surgery would have done a calculate procedure, and they would have gotten a good result, unless the patient had neuralgia. But let's leave alone with that. This shows you why they would have gotten a good result. Because there was no indication to do anything to the maxillary sinus. That cystic polyp was removed, and the mucosa behind it looks a bit swollen. Topical steroids will take care of that. Seeing this, understanding this, is the functional aspect of using an endoscope. That's what makes FES up there. So we need to learn and we need to understand, and of course we will talk about post-op care, etc. And if you look up there now, you see the same situation you saw in the beginning. The middle turbinate is there. Surgery has been taken to where pathology originated from. Skull base, sphenoid sinus is open, frontal sinus. You haven't seen it, but that's not important. You will over those couple of days. No need to resect the turbinate, and all of the cavity still has nasal mucosa. There is no significant amount of bone exposed. This is FES, the functional aspect of it. There are what used to be extended techniques 20 years ago, things which are standard today, like using the endoscopic approach for a small meningocele in a difficult place, behind the sella, which you cannot resect really. And here you're looking up with 45-degree telescopes behind the sella, identify the leak, the meningoencephalocele, denude the bone to get a good a receptor site for your grafts that you bring in, etc., etc., etc. All this is well known. Today, these are standard procedures. Today, those are the cases which it started 2 decades ago. The neurosurgeons would send to us because it was the experience that we, with our transnasal approach, could achieve a very good healing rate, over 90% primary closure rates, with less trauma than they could. Would we fail? They would still have the option. But reaching the clivus is not such a totally easy task. Here it can be, and there are varieties of closure techniques, and I will not bother you with details, but I just wanted to mention there are a lot of standards nowadays, and they not only apply to closure of CSF leaks. Here you see a bath plug technique where you squeeze a certain amount of fat through so that it expands intracranially and holds. And Mike Donald from South Africa, and after him, B.J. Wormel have published on that, Fastelat, etc., etc. I think we have enough chance to talk about that. Then there is the new fascination since about a decade. You've heard many groups, Pittsburgh. Look at that lesion, a meningioma, grown into the sinuses as well, but with a considerable intracranial extension, which you can see here. CT, MRI, image fusion is standard nowadays. It's there, and if you have it, use it. Okay, and I will again not bother you, but just show a few steps, and here you will be able to, sorry, my mistake. Okay, see that the dura, of course, has to be resected, and in this case, from the planus sphenoidale, actually from the beginning of the sella, to the posterior cable of the frontal sinus. So you can only start to do this if you manage, with a high degree of certainty, to close the large defects 2.5 by 3 or 3.5 centimeters, with a high degree of certainty. And this is a four-handed approach. You can see the navigation, what we have reached so far. Professor Mokri is using various instruments, CUSA, and all the things the neurosurgeons have, and gradually is exposing skull base. Krista Gully is resected. You will see how the olfactory bulb can be resected in cases of olfactory neuroblastoma, etc., etc. And with this, approaching the brain surface in a very, very good cleavage plane. So all that can be done. However, especially for us, for the neurosurgeons, it's a different way of looking at things. A way with fascinating quality of imaging, of the optical image. Amazingly better, they say, than what any time they were able to achieve transnasally with a microscope. For us, it is a totally different way to look at anatomy. Another field we have to learn, we need to manage, but here you can see, well, we've been above the orbital walls. We can look there with our deflecting scopes. We can go between the both frontal hemispheres, and again, we will talk about how to close defects like these. This is what the results can look. Just endonasal approach, not a single incision in the skin, with one exception, and this was in the thigh to harvest some fasciolata. So this is a new field of surgery which we have not started. We were actually behind, but sometimes it's very good to be a little bit behind the last fashion, developing things slowly, and we love to call that what it is, rhino neurosurgery. You take the nose as a corridor of approach and then do a variety of things we will talk about tomorrow and the day after. Again, I wanted to show those very short clips only to, yes, water your appetite. but water the appetite for the cadaveric dissection tomorrow, for the training, for the need to understand the anatomy, the variations, the need to be able to interpret CT scans, MRI scans, but well before that, make sure you understand the problem. And as we do not understand the inflammatory processes driving most of problems, we all accept is an inflammatory process. But a lot of these, especially the ones going along with very wild polyposis, have an immunological background. Little do we understand about fungal backgrounds, etc., etc. Think of Staph aureus, superantigens, etc., etc. As long as immunology is involved, we should always keep in mind that our surgery, in many cases, cannot be curative. With this in mind, we should think of a risk-benefit ratio. Can I control all potential risks? What is the situation of the patient? So all these are things that we should not forget about the sheer pleasure and fun, I know, of surgery itself. Having said this, I think we have now to ask you on, as we don't know your level, what is it we should demonstrate here? We have all the instruments that we may use, not the ones that you'll be getting for dissection. Many of these are way too delicate and they would not survive a cadaveric dissection. Initially, we have an external camera. We can show the instruments. So if there is, maybe you can ask in Bahasa, Indonesia, what kind of instruments the audience would like to see. Both Professor Mokri, myself, and Timo Hassa from Storz will be happy to demonstrate these to you and to try to explain why we use them, when we use them, though we will do it again tomorrow during the demonstration dissection. Okay. Step over here, that's not a problem. Okay, Lanungga, 30er Grad. Nach oben, also ganz normale. Einmal 0. Und einmal 30. Okay, otherwise I move over. Okay, the scopes you see here are all 4mm telescopes, and we have from top down 0 degree, 30 degree, and 45 degree. What does it mean, 0 degree? 0 degree means that you're looking straight forward. You have a certain cone of vision, but whatever you do with the endoscope, you always look straight forward. So you can turn it, you can rotate it, nothing will change in your image. This is the only endoscope where this is the case. It's the only endoscope where you point is where you look, is where your light is. This is not true for 30 and for 45 degree. 30 degree, where you look, is up here. And this is where your light is. Is that important? Yes, of course. Because if you look through both endoscopes, can I have one, say Blakesley, upturn Blakesley. If you look through both endoscopes, you will see a full circle, of course. And you see an anatomical structure or a surgical field, of course. The difference, however, is if your instrument enters the field with 0 degree, this is where you are. The same image that you will get with a 30 degree, your instrument, however, is up there. And with a 45 degree, it is even up there. This is crucial to realize, because otherwise, if you think you're working straight forward in the center of the image, this will take you 45 degrees away from the horizontal, or here 30 degrees away. This becomes even more complex if you start to rotate the telescopes. You will see that when you operate with the camera directly on the scope, like most of us do nowadays, and if you rotate the telescope to take advantage of the angle, looking further laterally or down or up or to the right, you should always rotate this against the camera, because otherwise 12 o'clock on your image does not correlate to 12 o'clock in the patient. And disasters have occurred because of this allegedly so simple thing. Because people were thinking, oh, I'm working up or straight down, but in reality they were going to 3 o'clock or to 9 o'clock, killing optic nerve, causing intracranial entry, CSF leaks, etc. So this is very important, and therefore one of the requests usually is try to get used to your endoscopes, try to do diagnostic approaches first, as you have heard, nasal endoscopy, office-based, very good to do it, and do it on the cadaveric specimen as well. Tomorrow the race should not be who's first in sphenoid sinus, but take advantage of the specimen and the anatomy that you do have. Endoscopes have become fairly sophisticated optical tools. There are, can I get the lateral light entrance now? 30 oder 45, whatever. Eins habe ich, 30, seitlicher. Okay, they differ with, oh, I have to leave it here, with the light entrance. Normally 45 degrees or 30 degrees are always opposite the light entrance. So when you go into somebody's nose, the cable will always be in relationship to the chin of the patient. Sometimes this is not very good because you are fighting for the space here. Therefore, endoscopes have been developed, and by the way, instruments who have their handle laterally, and endoscopes which have the light entrance laterally to give you space when you go up there and the cable goes over to this side. So you win motility and movement between the chin or the chest of the patient. Very crucial to realize, because if you're used to hold your endoscope like that in this scope, I would now look laterally and not up. Looking up is like that. It sounds very simplistic and it's all natural, but in reality this is frequently forgotten. If therefore you look through a 45-degree telescope, they are constructed not just because 45 degrees is such a nice number, but this is the last angulation where at the periphery of your visual field you still have an information about straight ahead. and that is exactly at 6 o'clock of the circle that you see. So if you want to advance a 45-degree scope, and this does not work with the 70 anymore. 70 does not have any straightforward view. And you look for your full circle with 45, look for 6 o'clock. This is the area that you are pushing your endoscope, or should be if you want to go straight. If you aim for the center of the image, you already deviate by 45 degrees. That's one of the reasons why so many trauma occurs. That you put your scope in, and you touch again here and there, drop off, and then you start to ask for irrigation devices, which make everything more bulky, etc. In reality, it is you are causing this yourself. And thousands of dollars of equipment can be spared to you and to your hospital if you simply understand how to use the endoscope. You don't need irrigation flushing devices. The companies don't like to hear that. But you don't need it. It is all in your 3 or 4 fingers that guide the endoscope. By and large, that's it. I would like to be very nasty here and show another thing. All endoscopes have front lenses. Inside there are glass rods, not simple small lenses like in your camera or in your glasses, but glass rods of several centimeters length, which break frighteningly easily, despite they have a stainless steel coating over there. So never hold an endoscope like I'm doing now. This may be enough to fracture it, let alone that you now have the weight of the cable. This is why these little handles have been designed to protect the scope and make it easier for you to hold the endoscope. The front lens is glued to the end of the endoscope. If you have the front lens frequently in alcohol, cleansing fluid, etc., this glue may dissolve a little bit, and then humidity may crawl into there. So if you look through a scope and it looks like mist or fog, that's the best guess. But again, this then was your nurse, your good self, who didn't pay attention. If you pay attention, we have scopes which last for more than 25 years now with excellent quality. So these are high precision, high sophistication instruments, optical tools that last. We are not through with the scopes. If you want to take videos or still photography of good quality, you must always know where the light exit of your scope is. I need you now at the camera to catch the tip of this telescope. Bitte? Okay, now I don't want too much light, otherwise the camera will get blind. That's quite okay. Okay, let me rest my hand here. So, is that okay? I can't look back there now. No, the tip of the scope. See the light? Know what I mean? Zeigen Sie ihm mal, was die Spitze heißt, wo das Tip des Endoskopes ist. This, okay? See that? And can one see that? You see that this is a crescent now? And if there is full light now, this will shine bright and bright and bright. But this little crescent is the only area at the tip of the instrument that gets very hot. In between the crescent, there's the optical pathway that you look through. This remains cold. The importance of that is, if you dip the crescent of light into blood, mucus, etc., this will dry and crust to the tip of the endoscope, not in the center where you look through. So you will always have a clear vision, but your image gets bad, worse, very bad, because there is some blood, some mucus on this little crescent that you see over here. This, therefore, needs to be routinely cleaned by yourself or by the nurse. It is not the light source, not the camera which is malfunctioning or poor. It is ourselves not realizing that this is where blood sticks, and therefore, of course, dims the available light. I'm still not through with that. If you have a camera on, most cameras have an automatic shutter, like with your photo camera. If you bring the light exit very close to a reflecting surface, it will get very, very bright, and therefore the shutter of your camera closes down. And then you cannot look very far into the depths of the surgical field anymore. The problem is not the camera. The problem is, again, us not realizing how to cope with that. I simply need to rotate away that crescent from the reflecting surface. And this crescent is somewhat different in different endoscopes. This was 0 degree. I'm now going to 30 degree. There are 3, and we need to understand that. And I go to 45 degree. This is now a lateral one. They all have different shapes, because the light needs to go around the corner as well. These are things that we would ask you to get familiar with before you start. It is so crucial to understand that. It is crucial in the sinuses, but it becomes even more crucial when you enter the brain. Okay. Anything that I've forgotten, Michael, regarding endoscopes? Yeah. Don't forget that where the light exits, there is a tremendous heat developing. It has been measured at 110 centigrade in the immediate vicinity of that tip. That's not a problem inside the sinuses. But once we enter intracranially and go beyond the optic chiasm, etc., as you will see, we must be very, very careful not to touch any brain structure with the tip of the endoscope. So we should not forget, by looking on the monitor, say, oh, that's beautiful or dangerous or whatever, that we have a burning hot rod in our hands. At the tip, it's over 110 centigrades. Very small area only, but it is there. So we should keep that in mind. So when you practice, think of it. Anything else? I see people yawning already, maybe a bit too much detail. Questions to endoscopes? Or am I talking too fast? I don't know. Okay. No question to endoscopes. I have no idea about prices. You have to ask somebody.
How about 70 degree telescope?
V?
70 degree telescope.
You rarely ever need it at all. The only indication or only situations where we use 70 degree telescopes are in rare occasions when we have to go to identify the anterior wall of a maxillary sinus, say when we do tumor surgery or resect inverted papilloma, carcinoma, etc., or once in a year, and that is for an average of 500-600 surgical procedures that we perform for the sinuses alone per year, once in a year for the frontal. Otherwise, the 70 is a very good endoscope for diagnosis. It is excellent to control a maxillary sinus if you operate it on a fungus ball. Look around the corner. And the simple trick to bring it in can be as follows. I need a trocar now. Und zwar nur die Trocarhülse. You take from the maxillary sinus trocar, you just take the hose, take a 30 or 0 degree telescope, put it over 30 degrees, And now you bring the telescope into the nose and look where you would like to see. Of course, 30 is not enough, but it's about the position. Then you advance the choker hose, stabilize this, pull 30° aus, Sie kriegen die rechte Hand 70 Grad. Hold that steady, ask the nurse to give you 70°. You go through with 70°, and either looking on the monitor or directly, you see where you are, and if the tip comes out, you are right in the place. Your lens will not fog, etc. So once you're there, you may then retract, whatever. But that's the relatively simple trick of, if you can't bring the endoscope 70° in, how to use it with the trocar hose. But it is, we do not use it a lot for surgery. Very, very rarely. Please go ahead. It's difficult for us to see. Just keep asking it. No problem. Nothing. Okay. Yes, please.
You mentioned about cleansing the.
Yes.
We cannot use the alcohol. We cannot use the soap. So what?
Oh, this is during the surgery. During the surgical 5 or 15 minutes again. We always have a little jar with Ringer's or saline solution, which the floor of which is covered by gauze, and we put the endoscope in, lens down. Of course, we don't throw it, but very gently. This will, to some degree, avoid sticking of debris to the tip of the lens, and then we clean it, dip it into anti-fog, and use it again. Okay. So, basic instrumentation. Can I have a Standard Curette, die gerade kleine? Blakesley gerade aufgebogen und an Kottel oder an Frier. Aufgebogenen Blakesley habe ich hier. I think with those instruments you're most familiar. It's just for demonstration right now of what we can use. So we have here an upturned Blakesley. Sorry, let me put it this way. Okay, we have a straight one. We have the curette. Yeah, this will roll down. I have to hold it, yes. And of course you need aspirators. These good old-fashioned instruments will help you do most of the surgical procedures. With those three things you can go through into the sphenoid. You can almost reach the, well, for frontal you need different things, but these are the most important basics. Add to that a Freer and or a Cottle, whichever may be your preference of instruments. The most important thing, like with all instruments, is that they are inserted under direct vision. So you shouldn't have the endoscope in place and fumble around until you see your instrument appear in the surgical field. Because before you're there, you have to pass through 5, 7, 8 centimeters of nose and sinuses. So make sure that you don't cause any trauma to the mucosa when you bring in the instrument. The position recommended is, if you're a right-handed surgeon, that the instrument should be always brought in lateral and a bit underneath your endoscope. Scope. Sorry, irgendeins. Irgendeins. Ich schreibe nicht durch. Irgendeins. Okay. Lateral to your endoscope and a little bit underneath, which will give you a range of motility of about 270 degrees around the tip of the endoscope. Don't try to undercross the endoscope. You will be in your own way. And this becomes very crucial when you do four-handed surgical approaches. And we will comment on that. Everybody then is fascinated and looks what's going on the monitor screen. But you should every now and then deviate your eyes and look on the hands outside the nostrils. There is competition for space as well, and the neurosurgeon need to understand your need to rotate lenses, etc. You need to understand the neurosurgeon's instruments, their working mechanism, if they have curettes, bayonet style, etc. And you need to know how you manipulate your hands not to interfere with your partner. This, by the way, and this is much easier once you see it being performed tomorrow, this is the congestion you have in front of the nose, why we would not use any optical-based navigational system. Because if now on your instrument and scope you would have to have those reflecting either LEDs or balls, whatever, usually 3 of them, whatever, if you need to route them and they must keep the line of sight to the detecting cameras, this does not work. It doesn't work very well. So the navigation that you will be seeing us using is always and exclusively an electromagnetic one. And I think this is the future for at least that field. If you're a surgeon alone, why not? Perfect. The accuracy of the various systems on the market is practically identical. The user-friendliness of electromagnetic systems is on top. Okay, so talking about basic instruments, and okay. Here you have the good old-fashioned Blakesley. You have the standard non-cutting one, and here you have the upturned non-cutting one. One thing, let me start the other way around. One thing that should never be done, or one movement that is forbidden during sinus surgery, is to go in, close your instrument and pull. Pulling is forbidden. It is a no-do, because you may easily turn the inside of the nose out. If for that reason a through-cutting instrument is of help, marvelous. Use it, but use it wisely. Again, going with through-cutting instruments will not improve the outcome. They will not change the outcome of your surgery. You can achieve, in most of the cases, the same you can achieve with through cuts with standard instrumentation. But for this you need to develop certain skills of how you handle the instruments. This is extremely difficult to describe. This can best be demonstrated while we'll be doing it on the cadaveric specimen tomorrow. But don't go there and pull. Any square millimeter, I'm exaggerating now of course, but any square millimeter of naked bone that you expose is 1 square millimeter too much. I'm not talking about tumors, of course, but inflammatory disease. Okay. Any question, anything that you have in mind when talking about Blakesleys? Should we demonstrate through cuts or whatever? But I guess you're familiar with those. So if you obey, not pulling, not creating trauma when you insert it, and whenever, if my arm is the middle turbinate, and of course there are conditions when it's relatively narrow anteriorly, and yes, of course, every now and then you really have to resect the first 5, 6, 7 millimeters of the middle turbinate because it leans against the lateral nasal wall. But this is the exception, every now and then. Usually you can nicely create space by going into the ethmoid with the uncinate, and then always have the blunt side of your instrument to gently push the middle turbinate medially, but you should not fracture it. That's the next no-do, not on purpose. That's a very crucial thing, because the ultimate technique or technology to avoid adhesions has not been invented. All the spacers, you name it, they do not work. Meticulous care during the surgical procedure, post-op care are the only technologies that really give you the best chance of keeping the entrance to middle meatus open. Say again. Okay. If you have a grasping instrument, like the Blakesley, especially when you enter posterior ethmoid and sphenoid, of course, with the subsegmentation and the intersphenoidal septum, do not rotate. Grasp them and rotate. Even if you have the feeling, no, I'm away from the carotid artery or from the optic nerve, in those regions, through cutting instruments are very, very much favored, because you can pinpoint at any millimeter you should go and nibble septations away. Do not go there. Grasp something, especially when it's thick, and rotate the thing. We all know from the reports and literatures, and those who do not make it into publication, that this can lead to disaster. And only work on structures you can clearly see with the endoscope. That's the advantage of using endoscopes, by the way, though it may be difficult, yeah, but you all know that. Okay, other instruments. Any questions?
Oh, okay. Good. So good morning, everybody. Thank you for waiting.
Good morning.
Good morning. And what we, the group here, Dr. Ungo, has kindly volunteered to assist or to instruct with me. Our plan to do is to show you, number one, the diagnostic approach, which always should precede any surgical step. I will do a ethmoidectomy. I will open all sinuses with the exception of the sphenoid sinus. We will not go into the sphenoid this morning because we need it in the afternoon for the transsphenoidal approach to pituitary gliders, intracranially, etc. I will do of course, the septum to your right. Look to the middle meatus. You can already appreciate the poina back there. Now, you start with the first of 3 standardized passes for diagnostic endoscopy. You go over the floor of the nose because this usually is the widest portion, and you try to get somewhere along this area towards the cranium. Try to avoid touching the mucosa because in a real patient you would pick up some mucus, it would be painful, it could even bleed. You can now nicely appreciate the posterior nares, the choana that is, on this patient's right side. To your right side you can see the vomer. To the left you start to look into the eustachian tube, and we are entering nasopharynx now. Now comes why you should use a 30-degree telescope and not a straight one, a 0 degree. If I stabilize the camera and rotate the telescope now to the left, that is to the patient's right, you can look into the eustachian tube ostium. In reality, I would now ask the patient to swallow, and you could see how the eustachian tube would open and close. You can pass on further and look behind the tubal cartilage into Rosenmüller's fossa, where we see a little friend which has, as it looks, died with the patient. Rosenmüller's fossa, unremarkable. This, by the way, would be the trans-epipharyngeal approach to skull base, to the jugular foramen, carotid artery, etc. We'll see that in the afternoon. Another advantage of using the 30-degree lenses, if I now rotate this back to 12 o'clock, you can see the insertion of the vomer. We look to the floor of the sphenoid sinus, and we now rotate over to the patient's other side, and we look straight into the eustachian tube ostium of that patient's left side. Should pathology or an anatomical obstacle prevent entering the nose on the left, you can explore the full nasopharynx with a deflecting lens. Rosenmüller's fossa on the patient's right side, vomer again. And you might even rotate further. This will show you the posterior side, the nasopharyngeal side, that is, of the soft palate. You sometimes can even see the uvula, and sometimes with a 45-degree lens, or here, you can even see the epiglottis. See, I tried to palpate, or could you do that, the larynx, and try to move the larynx. There you go. So we see open the piriform sinus on the patient's left side. You can see the epiglottis lean against the posterior wall, and you can see the uvula right at 6:30. But of course, this is not the standard way that we explore the larynx. This was the first pass that we do for diagnostic endoscopy. The second pass takes us back posteriorly again. This is the posterior end of the inferior turbinate, of course, And now you bring your endoscope up, identify the posterior end of the middle turbinate, and we try to go up between the nasal septum on our right and the turbinates into the sphenoethmoidal recess. And there you can see a superior turbinate. You can see a small supreme, a fourth turbinate. The hole to your left at 10 o'clock is not a hole, but this is an opening into the supreme nasal meatus. The superior nasal meatus is here. You see one of the cells opening near 12 o'clock. Then you can look into the supreme. You see the supreme turbinate, and this, of course, is the way into the sphenoid sinus. A wide and large, a huge ostium up here that brings us into the sphenoid sinus. So this is the second pass, and here we can nicely look up into the olfactory cleft and see if there is any pathology up there. The third and final step brings us now into the area of our main interest, and that is the middle meatus proper. Can I have the little curette? No? The J curette. The straight one, exactly. So here you can nicely see the anatomy. Of course, this is middle turbinate. Look at the elasticity. You can always take advantage of this. This varies from patient to patient, but we should never fracture that turbinate. Here you can see the uncinate process, anterior face of the bulla, and the tip of my instrument now disappears between the bulla and the posterior margin of the uncinate, which is, of course, the hiatus semilunaris. In that case, it will be able for me to enter the middle meatus from the front. I'm still with a 30-degree telescope, and I will now again take advantage of this scope by rotating it laterally. And with this I see, well, a little debris. It could well be that behind, yes, there is some mucus over, and all of you have recognized that this is not the maxillary sinus ostium, but just a small accessory ostium in the posterior fontanelle. Otherwise, if I would not have been able to enter from anteriorly, I would have brought the endoscope posteriorly, swing under that middle turbinate posteriorly, where the middle meatus is widest, and I would try to investigate from the back to the front. Now we see the bulla. I picked up a little mucus, the uncinate process, that's it. Aganasi up there, and very nicely we can marvelously see the bulla lamella, which here reaches skull base. Therefore, the frontal recess will have anatomically a very well defined posterior wall. This is important to realize for further dissection. What else could we see? And let's briefly switch to the patient's left side now and just do the same passes. Everything is mirrored right now. Inferior turbinate, let's move a bit faster. Eustachian tube, ask your patient to swallow. On the left you have the vomer going behind, looking into Rosenmüller's fossa. In the midline where you might find a Thornwald cyst, Rutger's pouch, look over to the patient's other side, and all this is familiar to you by now already. Looking up